So, welcome everyone. Those of you that don't know me, my name's Chris Carvalho. I'm a GP down in City in Hackney. I'm also a clinical lead at CEG, amongst other things. With us today, we have Mike.
Hi, I'm Mike Hanlon. I'm a GP, one of the clinical leads here at CEG as well.
And Joe.
Hi, I'm Jo Tissier, and I'm one of the senior facilitators at CEG.
We have some others as well in the background as well from CEG. But we'll kick off because there's quite a lot to get through today. And as I say, we're here today to talk about the investment and impact funds. We've got two different webinars. The first one today, we're talking about prevention and tackling health inequalities. And then after half-term holidays, 2nd of November, we've got another one talking about providing high quality care and sustainable NHS. You'll hopefully be familiar with the IIF and what that means and what that investment means to you as a practice, as a PCN and as a borough. What we're really talking about is how you can best achieve the indicator, or at least do the work that is involved in doing so. Our aim is to support you in understanding what is required, and to do that we have done the difficult task of interpreting the business rules that NHS Digital have released on those indicators. Unlike QOF, these aren't already in EMIS and System 1. They've had to be built and then imported in. The searches that we have developed, which are for guidance only, these aren't the things that will be the way that it is determined how you are paid, but this will help you understand your current performance and what you need to do. These are in the folders in the PCN contracts folder within EMIS. This is screenshots there. And there's also within the templates a link to the IIF dashboard, which I'll come on to in a minute. One of the key things to say about these is that these rely on specific codes that are used to extract the information that helps to understand whether you are achieving or otherwise. Some of these are IIF specific, and there will be other codes that you will need to use to achieve your local contracts. What we have done is, because we have that knowledge of the local system, is match them so that if you are achieving something that is in both your local contract and in IIF, you're going to achieve it for both using that in that single code. So the recommendation there, very clearly, use the CEG templates. You will then be able to achieve both because they have the local knowledge and the local codes that you need to achieve them both. If you have any questions on that, we'll go through this at the end, but we have our local facilitators, our primary care support officers, who can help you understand all of this. If you're unsure, if there's any questions you have, we'll put the details on how to contact your local local liaison at the end. So moving on, let's see the dashboard in action. Do you want to?
Yeah.
So what we've done is to help understand your current performance. It's easiest to show this as a dashboard, as a visual representation of your current performance and what you may need to do to improve or to move forward. So on this dashboard, you'll see that it has the indicators for the majority of the IIF. And they're also split into those different domains. So prevention and tackling health inequalities, providing high quality care, and then a sustainable NHS. And I'm going to scroll down quite quickly. You'll see these all split up on there. That in itself needs a bit more of a breakdown. So what we would need to do is to go onto one of those domains. And you can see then those are the indicators there. But also, I want to know how I'm doing in my PCN. So at the top here, I would pick out, select all. If I select City in Hackney, I work in Shoreditch Park in the City. Hang on a second. Deselect all of the others. Then I want to select Shoreditch Park and the City. And that will pick out the current performance here. And you'll see current performance, the shortfall, and the upper and the lower targets. But what's more helpful is this part here. So if I select one of the indicators and go with CVD05 on DOAX, This will show you your current performance, the upper target, the lower targets, and the population you need to focus on, the numbers that you need to hit the upper threshold and the lower threshold. So it gives you an idea of the workload that's going to be involved. But to also know, what's also helpful to see is your performance as a borough, as a PCN, and within your own practices as well. Diplomatic for those practices that are included in there, we're not yet at the end, so there is some way to go, and we know these practices are working hard. So they're not at the upper threshold, they're in the middle there, they are doing work, and so no criticism of any of the practices in there. But that shows you where you are in comparison to your PCN, and you can also do that to your borough as well. So if you wanted to do that, if you come back up, let's select all, deselect all, and say we want to do on City and Hackney. I'm doing this very quickly because there's a lot of information to get through, but if we say we're going up to the top, so click on City and Hackney, you can see your boroughs, and you can also see all of your practices there as well. I'm going to move off that because some practices may not want to see that, but that allows you to see the breakdown by practice. We have all of those different indicators. One slight thing to be aware of, there are some indicators you're needing to go up and you need to improve your performance. There are a couple of indicators that you need to go down on, that you need to take people off and reduce your performance on there. The caveat with this is, again, that we have interpreted the business rules. These are for guidance so that you have an idea of what your performance is, and it's there to help you think about what you need to focus your areas on, what you need to do to improve. But this isn't going to show you that if you achieve the performance on here, that is set in stone and that is your payment. We always recommend with all of our contracts, even the ones that we are much more closely involved with, that you overshoot the mark, that you do the things that you need to take you above the thresholds. So that way there's a bit more reassurance that you are going to achieve your indicator. All of these indicators have been determined because of clinical need, that these are things people should be on nationally. So there is a clinical benefit for doing these for the most part. So we would make sure that you would want to do these anyway for clinical indications. If we move back now to the main slide deck, is there anything else on there we wanted to cover? Have we covered everything?
I think that's covering everything, yes.
Okay. So we're going to go through the first, really first two domains of those IIF indicators, because there's a lot on here. Bear in mind, this is new to you, this is new to us, but we hopefully are familiar with the processes, because effectively this is QOF, but for PCNs. So I'm going to hand over to Mike. And we're going to carry on through with those different indicators.
Lovely, thanks, Chris. So I'm going to kind of cover the different health inequalities indicators. So they're separated into sections that cover vaccinations and immunizations, learning disability, ethnicity, and CVD prevention. So starting with the vaccine indicator, so there are three indicators about flu vaccines, and these are broken down by different age and risk groups and have slightly different thresholds. Now, the IIF indicators are in addition to the £10 and 6p item of service that practices get per vaccination delivered, okay? But flu vaccines have been removed from QOF, and in a way they also slightly differ from how it was in QOF, is that there are kind of exception reporting available, which are called personalised care adjustments in IIF. So if you invite patients to have a flu vaccine and they don't respond to the two coded invites, that counts. Okay, so that's what's slightly different to where QOF was. So really, the main take-home is getting those invites out, so that you've been able to send out at least 2 invites. Anything else?
I should have said, one of the things that we're really interested to understand is what you've done already. We're halfway through the year in achieving these IIF indicators, and in different areas, in different practices, in different PCNs, and in different boroughs, you may be doing things differently. And so in the chat, please put in things that you are doing within your areas to help achieve these different indicators. anything that would be interesting, anything differently that you've done, how you're working as a PCN or as a borough to achieve this, and so that others can learn from each other, because this is a really collaborative piece that we're hoping to bring to you through these webinars, and also sharing how you're looking at the data as well will be really interesting to understand. So please put things into the chat. Anything that's interesting there, we'll try and pick out and expand on, may ask you to talk about it. And also if you have any questions on these indicators as well. Thanks, Mike.
So moving on to the next indicator, which is learning disability. So this is looking for patients that are 14 or over who are on the LD QOF register, ensuring that they have an annual health check and health action plan completed. Now, the IIF targets again are in addition to the £140 item of service DES fee payment that the practices get. Okay, and there is a personalised care adjustment for patients that are declining a learning disability health check. Now we have a set of templates to help practices enter the right codes to make sure that they are kind of recording that they're doing this work so that they're able to meet the targets. So we would kind of refer people to use those templates to code either whether they've refused or making sure that the health check and the action plan are recorded. Anything else before we move on? No. The next health inequalities indicator is about recording of ethnicity. It's a fairly self-explanatory one. It's covering all registered patients and making sure that the patients either have an ethnicity recorded or one of the two kind of not stated or declined codes. Again, we have templates to help surgeries complete this, but the key take home really here is that there is an Accurix Florey text message kind of questionnaire that you can send to patients, and we have searches available to identify patients who don't have one of those codes coded on their notes, so that you can proactively ask them to reply with an ethnicity, and that will automatically code that in the notes. So it's really, really helpful. It's up to practices then to determine how they want to handle patients who don't reply to those text messages and don't have an ethnicity coded in the notes, whether they think about using something like ethnicity not stated or not. That's a decision that practices will need to make and then PCNs will need to make. And that brings us on to the cardiovascular disease indicators. So the first one, CVD01, is about patients who are not on the hypertensive register already, but who've had an elevated blood pressure, and it's split into two different cohorts. The first is patients who had a raised blood pressure recorded in the 2 years prior to the start of this year on the 1st of April. And the second cohort is about patients who haven't had that, but have had a raised blood pressure reading of over 140/90 on or after the start of this year on the 1st of April. So what do you need to do for these patients? So if they're in that first cohort where they had the raised blood pressure within the last 2 years, but not this year, if their first recorded blood pressure this year is normal, great, you've achieved the target for that person. Just to be aware though, should they subsequently have a blood pressure in this year that then is over 140/90, they're back in under the second cohort. If they have had a raised blood pressure since the 1st of April, so moving on to the second cohort of patients, you need to do one of these things within the 6 months of the date of that raised blood pressure reading. Okay, there are a few things you can do, but the ones we would recommend are either asking them to complete a blood pressure, so a home blood pressure diary or an ambulatory blood pressure, so referring them for that. If you use something like the Accurix Florey home blood pressure diary of 7 days, it will automatically code blood pressure recorded at home when that result comes back, and that will then count them as achieving that IIF target. The other thing that you can do that we recommend is seeing if you can get them onto the QOF hypertension register and either starting them on antihypertensives or coding that they've declined antihypertensives. And the reason we'd encourage practices to try and do that is there is another linked indicator about increasing hypertension diagnosis prevalence, and it will help to achieve that. There are some personalised care adjustments for this one. So if patients' first raised blood pressure of the year, so if they're in that second cohort and their first raised blood pressure is in the last 6 months of the year, so it's since the 1st of October, they will actually roll over into next year's IIF indicators to give you a bit more time to do that before the end of the year. If they have declined doing ambulatory or home blood pressure monitoring, that also includes, they're then excluded as a PCA. But do just note that declining a blood pressure reading in clinic isn't enough to count. It won't trigger the PCA. So it has to be that they're declining ambulatory or home blood pressure testing. So that brings us on to the linked indicator that I was mentioning before, CVD02, which is about your prevalence of patients who are registered as having having hypertension on the QOF register. What they're looking for is an increase in your prevalence of 0.4 to 0.8%. So by that, sorry. So if your prevalence was 1%, increasing that to 1.4 or 1.8%. Now, the slight caveat with this indicator is that actually it's looking at all registered patients. Okay, so that's including children. Okay, so it's just to be aware of that. It's also slightly unclear as to how National are going to be recording what your prevalence was at the start of the year. So what we try and encourage practices is to try and overshoot that upper threshold as far as possible, to make sure that you're getting the maximum that you can.
So one of the things that we know in North East London is that we are very good at hypertension management and control. But one of the things that is a national issue is the detection of hypertension, and that across all areas, and this includes North East London, we haven't found all of the people who have high blood pressure. Now, the earlier we can detect it, obviously the better it is for an individual and the better it is for their control. But there's some work to be done around that and making sure that we have the services and systems in place to detect. 24-hour blood pressure monitoring was always seen as the main way to diagnose. The other option is the home 7 days readings. And interestingly, we have found data that shows that lots of people actually have their own machines, and there are lots of people who know other people who have them where they can borrow them from. But there are other schemes in place, and just to highlight and recommend, there is a service within the within pharmacies to detect or case find for hypertension. So please link in with your local pharmacies on this as well, and direct patients to have their blood pressures checked there. We have a map across now of showing which pharmacies are involved in that scheme, which we can share afterwards as well. So we hope to use all of the systems, all the things in place to be able to detect as well. And the key message there is that we haven't found everyone that we need to. But in North East London, we are good at hypertension. So I think this should be something that we should be able to achieve. There is some work to be done, and we appreciate there is a huge amount of work that is a workload around the PCN, so the IIF does. But I believe that this is something that we should be able to achieve, and there's a clear benefit to our patients on that.
Great, thanks, Chris. So moving on to the next indicator, CVD03. So this is looking at patients who have a QRIS score of greater than 20% who are currently treated with statins. Now, according to the data which we have, which is for guidance only, it does look like everyone's actually already achieving this. Okay. But something to be aware of is that this indicator is looking for either that the patient's declined a statin or that they've been prescribed as they're currently treated, which they define as being prescribed in the 6 months prior to the end of the reporting period, so the end of the year. Okay, so really the prescription will need to be on or after the 1st of October. So it's just to be aware of that those numbers could in theory change. So just for everyone to kind of carry on doing exactly what they're doing.
Okay, I'll take this on because this is a bit of a deep breath moment with this indicator. You would have seen that there was a letter from national team updating and in fact removing some of the indicators. But for this one, CVD04, they have in the letter changed the way in which it is recommended to address and to achieve. Looking at the target itself and in the words that are up above, it is saying that you need to refer everyone who has a high cholesterol into secondary care. Clinically, that's not necessarily always appropriate to be doing. And there is more to determine what someone's risk is of having familial hypercholesterolemia. We have criteria such as Simon Broom and the Dutch lipid clinic criteria, where that will assess whether someone is high risk and likely to have FH, and they would benefit from having further investigations to determine if there is a genetic component to that, or whether there is further that needs to be done in terms of the assessment. With the indicator now, according to the letter, this emphasizes more about the assessment that needs to be done first in primary care. From a clinical perspective, what we want to do is determine whether or not someone has high risk for familial hypercholesterolemia, or whether that cholesterol can be determined by another reason. So with this indicator, what we are recommending is first to run the search and find the people who have high cholesterols. We have a pathway, and in that, it then says to do two key things. Firstly is to check for secondary causes. Check for alcohol, thyroid disease, diabetes, check their drugs as well. And alongside that, understand the family history. With the family history, what we're particularly interested in is whether somebody has a first-degree relative who was under 60 when they had the cardiovascular event, mainly the heart attack or angina. So did they have a ischemic heart disease event before the age of 60? And by first-degree relative, will mean mother, father, sibling, child. We have a flowchart which will help you to understand which codes to use for that family history. And then alongside the secondary causes, there is a referral template which will pull all of this out for you then to determine what their risk is using the Simon Broom criteria, and then access secondary care through advice and guidance or otherwise to determine what their risk is and whether they need to have any further investigations. Obviously, there's an exception on this, and if they decline that assessment. However, looking at the letter, all you'll need to do is look for the secondary causes and do the clinical assessment, and if necessary, refer, or look to see if they already have a genetic diagnosis. The difficulty that we have at the moment is that the national team haven't released the business rules to say how this is going to look, and so we can't do the extraction yet to see your performance. But if we're following the principles of the IIF, which are around the clinical justification and the clinical guidance on taking approaches to achieve these, the recommendation is there in the NICE guidance to do the secondary cause assessment, the family history, do the risk assessment, and then to use the template. We have developed the pathway. There's a bit of an explainer with that as well. That's gone out to borough clinical leads to disseminate, and we will be sharing that soon. We're hoping to do an education session later in the year. The difficulty is we only really have 6 months left, or less than 6 months, to achieve this in. So we're running to a very tight deadline on there. But we're sharing this as soon as we can to be able for you to understand how to achieve on this indicator. Hope that makes sense. More sense will hopefully be made when you look at the pathway. It is very complicated to do an assessment for familial hypercholesterolemia, which is why we have the pathway and the template. There is a national guidance through the Accelerated Access Collaborative, the AAC, which has produced a lipid pathway, a very comprehensive document on how to address lipids. In that, to do a family hypercholesterolemia assessment, their one line is effectively assess for secondary causes. So what we've done through the pathway is break that down and hopefully made it much clearer for you to understand what needs to happen in that assessment. Happy to share that with all of you as well, and we can put some links through, but the flowchart is going through your borough leads for dissemination and should be with you hopefully pretty soon. I'll look out for any comments on that on the chat, and we can maybe discuss a little bit more of that as we go through the year. But I'll hand back over to you, Mike.
Brilliant, thanks, Chris. So the next indicator is CVD-05, and this is looking at patients who are on the QOF AF register. And slightly different to the normal QOF is that rather than just looking for all patients with a score of 2 or more, this is also looking for male patients with a score of 1 or more. And it's rather than just looking at purely whether they're anticoagulation or not, it's looking preferentially at DOACs. Okay, so, and if they aren't suitable for a DOAC, then thinking about warfarin. So there are some care adjustments or exceptions in this, and this is if they've got a new diagnosis of AF in the last 3 months of the year, or if their patient's declined or not clinically suitable. But there are a few things that you need to do to code that because of what I mentioned about DOAC. So the real take home with this is that there needs to be some indication. If patients are on warfarin, it needs to be clearly kind of coded in the notes that there is a reason that they're not on a DOAC, so that they've declined it, and if they've declined it, that needs to be within the last 12 months. If there's a contraindication to DOAC, that can be at any time. Okay, and an antiphospholipid syndrome is one of those codes, for example. Mechanical valve replacement is also one of those. So the things that you need to do, any of those criteria, will allow you to reach that target. And we have an APL tool, the AF tool, to kind of help practices find and identify those patients as well. With regards to exclusions, so there's quite a few different criteria, but they need to meet at least one of those things in order to be excluded. So if they don't have a valve replacement, you need to have a combination of those codes, basically indicating that both are either unsuitable for whatever reason, whether it's declined or not indicated or contraindicated. And if they are on warfarin, their time in therapeutic range needs to be over 65%. They can also have an anticoagulation declined code, which can account for both. Okay, and as I mentioned, if they're diagnosed with AF in the last 3 months of the year, they will be excluded also. That brings us on to a slightly linked indicator, CVD-06, which is about the number of patients that are currently on edoxaban. Now, the NHS managed to negotiate with the manufacturer of edoxaban a price that makes it the most cost-effective DOAC. So there's real encouragement for patients to be put on edoxaban preferentially. So it's up for practices to kind of decide how they want to move forward with this, whether they want to consider switching all other anticoagulation patients that could be switched onto edoxaban, or whether they want to think about patients who potentially just switching from warfarin to a DOAC and putting those preferentially on edoxaban, and new patients on anticoagulation and thinking about edoxaban. Chris, did you want to just come in with the okay.
Sorry, just to say that with this, there is obviously a move towards using edoxaban as the preferential anticoagulant, and there are benefits of using DOACs over the warfarins, but there are also the benefits to the health system of using a cheaper DOAC, and that is the way that the NHS England are moving towards in the prescription of edoxaban. One of the issues around DOACs is that many of us are still unfamiliar with initiation, and in the different boroughs there are different ways in which you can initiate them, through clinics, through hubs, but all GPs should be able to initiate DOACs if they feel comfortable to do so. And so there is guidance out there for you to be able to initiate. If you don't have access to it, we'll make sure that is available across the borough in the across now. One of the other issues around edoxaban is that actually many of our patients who are on DOACs are on a different DOAC. And as we have seen through this, one of the options, which is not something that we are suggesting one way or the other, but one of the options is to switch people. This needs to have very careful consideration, and I know that medicines management teams have had discussions around doing this, and that has been discussed at different borough levels. Looking at the indicator and looking at sort of the current performance, if you were to take people who aren't on a anticoagulant who should be and start them on endoxifen as a preference of the DOAC, and those people who are on warfarin with where it may not necessarily be clinically indicated to be where it is clinically indicated to be on warfarin, then we should be able to get some way to achieving the indicator. Mass switching has some controversial ideas and topics and discussions around it. And there is a discussion between obviously yourselves and your patients and your medicines management teams as to an approach you can take. From our perspectives at CEG, it's not something that we are suggesting that is a first option, but that is something that you may want to consider. And I will leave it, I think, up to yourselves and the medicines management teams to discuss further.
Brilliant. All right, thanks, Chris. All right, so that brings us to the end of those set of indicators, and we've got a section now for any questions.
There was one question in the chat around a patient who had a high cholesterol of 9 in 2003, whose cholesterol then subsequently came down to 4. And then what you would do with this patient, because you know, is this someone that you would then assess for familial hypercholesterolemia? I think for me the question there is why was it high, and what happened for it to come down? Was there something there which made that there was a secondary cause to the high cholesterol? It may well be that you have patients who have familial hypercholesterolemia who are treated and managed, and other things happen to them. But there's also an impact to them and their family as to whether or not this was a true familial hypercholesterolemia. So an assessment, I think, there is still relevant and important. And so, as the letter had said, assessing clinical assessment for familial hypercholesterolemia is still needed. I'll answer that question. That's not to say they necessarily have to go and be referred and have genetic testing, but that may be that that you have done the clinical assessment, which would mean that they have achieved the indicator according to the letter. We'll give it a minute to see if there's any other questions on there. Hope that has been useful. We've gone through that pretty quickly. And while we're waiting for some more questions, if we carry on through and look through what we can do to support. So at the beginning, we mentioned there are searches. So we have the IIF indicator searches there as a guidance. And in some cases, there are also support searches as well to help you achieve on that. We also have our templates, whether that's our long-term condition templates or our hypertension diagnosis templates or otherwise, all within the systems. As long as you are using the CEG template, you should then achieve both the IIF and the local contracts. So please do have a look for them for further details. If you need support, if you need some help, we're able to do some practice visits, either virtually or face-to-face, from our friendly team. You can see there on the photos. And then also, there's the link to the dashboard. Now, this is updated monthly. We are a little bit behind on that because we were updating the changes from the letter, but that should be with you soon. But then in the run-up to the end of the year, that will be hopefully with you on a monthly basis. We're currently showing September's data, so it's not too far out of date. There are other dashboards as well you should be able to access through that link. And also on that website, you'll be able to see the different tools that are available to help you across not just the IIF indicators, but the rest of the clinical improvement work that we support with as well. The next slide, you'll see a map of North East London, which also has the email addresses of your local support teams from Tower Hamlets, City and Hackney, Forest, Newham, and BHR, many of whom have been answering questions in the chat as well. Okay, I think we've got a hand up. Sorry, I heard a voice.
That was me, Ranjan. There was a question in the chat about Nell advising not to swap edoxaban if stable on another DOAC.
Yes, so absolutely. So that is what we aren't doing here as CEG is recommending a strategy or a way forward on that. And there has been a lot of discussion and debate around the ways to achieve this indicator. There's also some work coming and some support coming to help of the anticoagulation of patients who have AF, which hopefully should be implemented or approved pretty soon. In terms of the switching, though, absolutely, this is something that is a clinical decision between yourselves and the patient as well. And we are not advocating for switching. And the medicine management team have rightly suggested that people who are stable should remain on that for very good reasons, such as the patient preference, but also their acceptance of that medication. So that is a individual discussion, and not something that we're suggesting is a mass switching approach. The debate there is that there is benefit to the health system because of the cost saving, and that's why NHS England are recommending moving to edoxaban. But for the purpose of this discussion, that's not something that we're necessarily advocating. We've got some other hands.
The hand up is Suzia.
Yeah, hello. I just wanted to talk about the System 1 searches and their dashboard. I've raised it with Faye and the CCG as well. This is a big problem because if in a PCN we've got two practices that are System 1 practices, we still can't see them on the dashboard, on the IIF dashboards, their activity, what they are achieving, so we can get back to them and tell them, you know, these are the ones we need to work on. So now 6 months are left. Is there any possibility? What do we plan? What would be the time frame to get those details on there for them? Ardens have got them, and we have come to the point we are getting it from Ardens, you know, from one practice to another to help them with those searches and with their targets.
Hi, Susie, it's Faye.
Hi, Faye.
Hiya. We have got System 1 searches out there, and as I've just explained to Asia in the chat, we are updating them at the moment with the latest guidance, and we are in the process of getting them in the IIF dashboard. We're just trying to do the background of it so that the IIF dashboard can read the outputs from System 1, but they will be there shortly.
But that's okay. I understand. And I know it's a lot of work for you guys as well. I appreciate that. But, you know, seeing the time frame, seeing how hard it is for the practices, we talk about equality, you know, in our general Bolton Forest, how we can make everyone equal. But I think EMIS and System 1, System 1 are a bit behind all the time. And they're now asking us, and we're like, okay, we can get Arden search, but I don't know how Ardens get it all, right? How they have got it. They've already got those.
One of the additional things that we need to do with our searches is make sure they also match up with our local contracts. So when we are looking at that performance, we need to make sure that the code sets match, because otherwise you may achieve in the IIF indicators, but you won't then necessarily achieve in the local contracts. So what we have to do is we have to do an extra step into interpreting those searches and codes and templates to then transform them in. We are going to do that. I think what I'm going to do is we'll have a chat with Faye about supporting those practices to make sure you've got some information in the meantime, because you're absolutely right. 6 months to do a lot of work. It doesn't give you much time. So we'll work hard for those practices that have System 1 to try and get you up and help you as a PCN as well. We'll have another chat with this offline if that's okay, and make sure that we're doing what we need to support all of our practices.
Definitely. Thank you so much. Thank you.
Thanks.
Mira, you have your hand up. You're muted.
Thank you. Yeah, the practice manager. I'm not a clinical person. This regarding this hypercholesterolemia, familial hypercholesterolemia. The code is only, we can only add the code that the patient has been referred, because I didn't catch the explanation actually previously. I'm trying to look for my clinical pharmacist. Say he has gone for lunch. So the thing is, he raised, because he nearly we have our list nearly about 60 odd patients. Out of them, 13 patients are we have referred and we have addressed, but another 40 odd patients, they are not really suitable for the referral. And also they previously, nearly a good few years ago, nearly 10 15 years ago, the cholesterol was 7 above 9, but gradually it has come down, because we were really managing very well them in-house. So they're not really suitable now for them to be referred. So how can we get them exempted? Even the decline code is not really bringing up the target up, and they're not really suitable at all.
So one of the difficulties here is that for us to understand which codes you need to use to help us to develop the searches, to develop the dashboard, are reliant on business rules. And this is the documents that NHS Digital release, which show us all the codes that they will use to extract the information that you have done X, Y, or Z and achieve the indicator. Initially, they developed these, and the only code they would have for this indicator to show you've achieved is referred for assessment of FH. Although actually, when they released those rules at the beginning of the year, that code wasn't even available in the health record. What they have done now is they've released a letter saying what that's, they have released a letter which has said what the indicator is asking you to do, but they haven't updated the business rules to say what those codes are yet. I've been assured that will mean they will have had the achievement, and I'm going back and back to national team to ask when they will update that. But based on that, what they have said is that if you have assessed an individual, that will mean that you have done what you need to do for that indicator.
Absolutely, yes.
And you're absolutely right not to refer people who do not need to be referred, because what you'll have is two things. One will overload the secondary care, who means then they won't be able to do appointments for other people who do need it.
And also, patient also doesn't want to be referred, because if the cholesterol is within the range, they don't want them. They don't want them to be referred as well, actually.
So then there's another thing in that if you do refer them, you'll get it bounced back to you because you haven't done any of the workup for them to know whether or not they do need to be assessed. But then also, and I think this is really important to emphasize, familial hypercholesteremia is a life-threatening condition. I mean, it may be exaggerating it, but effectively you're telling someone that they are at risk of a heart attack. And it doesn't have just implications to them, it has implications to their family as well. And so when we do a referral, if we're referring them and we're explaining that to them, we're then leaving them in limbo of going away with this anxiety until we get it back from the secondary care to say that they are or aren't at risk. Whereas actually what is clinically right to do is to do that risk assessment and to tell them, well, yes, you have a high cholesterol, but it's because of your thyroid disease, or it's because of X, Y, Z. But also we've done an assessment, and although you've got this high cholesterol, you are low risk for having this inherited condition. And that's a really important message to be giving out to the patients. And while the indicator itself has a very clear and right justification in trying to improve the diagnosis of, or the prevalence of FH and the diagnosis of FH, the indicator hasn't been worded in the best way to do that. I expect this indicator to change dramatically over the next year. And hopefully it will show us a much better way of taking this forward. But the key thing is to assess for secondary causes, get the family history, do that clinical assessment, and apply the criteria, and that should show that you've done the right thing.
Okay, so what is the code we have to use? Because most of them have been assessed by our clinical pharmacist.
I would very much like to be able to tell you that, but it hasn't been told to us either. What I think we might need to do is have a code in place that we might need to then adjust when it comes to it, but that's really tricky and it's not good data quality. So we've held back from doing that because we're hopeful to have that new new business rules. But if it comes to it, then we'll have to put that out there. Leave it with me, because I have been on at the national team since the indicator was released, that this isn't the right way of wording things and the right approach. So we've managed to get some change, but as soon as we get the rest of the details, I'll share that with all of you.
So I can convey the message to the pharmacists then, so they have to assess the patients, but they still have to, we shouldn't be adding this code unless if the referral is needed, but eventually we will get the code from the CEG KEG.
Yeah, use the flow chart and make sure, because it's a very easy thing to do, if there was a clear secondary cause to it, that you can pause for secondary hyperlipidemia. But otherwise, we will release the code as soon as we get our hands on it.
Okay. Can I get the flow chart, please, so that I can just show it to the clinical pharmacist for them to just follow?
Yes.
We'll
I'm
send
happy
it
to
out in the
share it.
template.
We'll share it afterwards.
Okay.
But just to be clear, that technically speaking, it needs to go through the borough clinical leads. But I'm happy to share it with others as well, and I will also share the AAC pathway. The AAC pathway is busy. It's difficult to follow, but we'll hopefully release some more information through some education sessions as well.
Right. Okay. Okay. So we can. So when we get the new code, because most of the patients are assessed by the pharma clinicians. So when we get the new code, can we go back to the patient's records and edit that, because in order to get our targets up by the 31st of March?
That should be okay to do.
Should be okay. Perfect. Thank you very much. Thank you.
One thing with that indicator as well is getting the family history, as said before, isn't always easy. And so data that I've seen through CEG shows that the coding family history code isn't always accurate enough for us. It's not easy to get family history. It's not easy for a patient to know their family history. What we need to know is who it was and at what age they had that event. One of the options that we have been working on is to use a text-based questionnaire that we can send to patients that they can fill out in their own time and spend time going back and forth to get the right information from the right relatives to be able to fill out and complete. Ideally, that would be through Acrix. They don't have that. They don't have it though, unfortunately, and I have been talking to them about developing it. But it isn't something which they will be able to do anytime soon.
Right. Okay.
However, the other service that is available in North East London, One Contact, who were involved with the pulse oximetry, with the long COVID referral form, they are about to release that text message family history questionnaire. And that will then allow you to send it out to the patient and complete it. But they're in that pathway, in that flow chart, it will show you how to get access to One Contact, which is free to all practices.
Right.
There's a comment in the chat around custom florries, and this is one of the things we're discussing with them. It doesn't give you the correct logic to be able to put the codes in. So it says it can ask a question, and based on that response to that question, you can then add the right code in. But unfortunately, it doesn't make it easy for the end user, the patient, to understand really the way in which you're asking it. What you need to do, and you'll see in the flow chart, the way that you will need to ask the questions, that it depends on a if this then that, and if this then this way. So it follows different flow charts or pathways depending on your response to the previous question. And the custom florries don't allow you to do that at the moment. I am discussing with them as the way that they can do this and develop it themselves. I don't know how quick that will be. So in the meantime, if you want to use the text message questionnaire, sign up to One Contact and it should be with you hopefully very, very soon, but much sooner than the Acrix one will be.
How do I sign up for the questionnaire?
The One Contact questionnaire, the details will be in the pathway.
Right. Okay. And the pathway also, I can't find that on the chat or on your
we'll be sending that out through to you as well. But just as I say, that ideally should go through the borough leads first. But we'll send you a copy if the borough leads, the clinical leads, some of you are on the chat, are happy for us to do so.
Right. Okay. Perfect. Yeah. Thank you very much. Thank you.
Any other questions? Just on the how often the dashboard gets updated, that gets updated monthly, and it will show you the performance of the on the first of the month. As I say, we're a little bit behind on this because we need to make the changes that the letter that came out at the end of last month has implemented, but that should be ready to go soon. There's a question in the chat around the piece on CQRS comes in. I'm not sure myself around that. I'm not sure, maybe I'm misunderstanding the question there, so it might be helpful to put that back in, or to stick your hand up and we'll ask you to ask that live. Go ahead, do you want to ask that? Sorry, you're on mute.
Sorry, just in 21-22, we had to go on to CQRS to basically make a couple of submissions regarding like flu vaccinations, etc. So, but the whole system of CQRS, it has all the IIF sort of indicators, but it's quite confusing how to navigate CQRS if we need to do anything to ensure payment is made.
My understanding is that they're using a different system to extract the data on this rather than through that, but maybe we're looking at different things, so we'll pick that up with you offline, and if there's anything else that's useful to the group, we'll share that with you afterwards. But thank you for raising that. We'll pick up that afterwards. Any other questions from anyone else? Just to flag while you're putting those in, with the webinars, we've got another one on the 2nd of November, but there is also a webinar tomorrow on the new cancer tools. So if you haven't seen that already, if you get in contact with the email addresses that are up on there, we'll be able to get you to sign up to those as well. There's a question around DOAC patients. So if the patient has not been diagnosed with AF, the CG tool does not work. So with AF and with the DOACs and with the edoxaban, what we're asking here for is really just those patients who have AF. And that is the main ask of the initiation here of DOACs, and particularly edoxaban, only people who have been diagnosed with AF. Okay. Any other questions? I hope that's been helpful. I think it would be good to hear a bit more of what's happening in different areas, any particular innovations, any projects, any things that you've implemented, and how you were achieving this. I think we've heard a little bit about some of the different workforce that are involved to achieve this, and a big shout out to our pharmacists, where a lot of this work is going to be involved with, particularly around the DOACs, but the statins as well, and some of the desktop reviews. I think some of you from BHR and others will be familiar with the work that's happened there, and particularly the great achievement of the pharmacists on anticoagulation in AF patients, and also the work they're doing with cholesterol as well. So some great work happening out there across now. I think the dashboard shows that there is still some work to do, and there is a big amount of investment that could be coming into the area. And one of our aims from this is to start to increase the collaboration across NEL. We realise that as different support teams across NEL, we're getting a lot of the same questions, and so it was important that we worked together as a team to make sure we had an offer that met your needs and helped improve the care for our patients. So hoping to collaborate more, and it'd be good to bring together some of the PCNs, the CDs, to understand more about what we can help to support you on, and what you need from us to help in terms of the data, the searches, the tools, and some of the feedback that we can take through to the other teams as well. So just put a comment in there about hypertension case finding, and using a freestanding BP machine can be helpful as a first-line approach for those patients with borderline BP results. So just on that indicator, CBD-01, those patients who had a reading that was high before the 1st of April, if they've got a subsequently normal reading, then that means they have achieved the indicator. Those people who have had a high reading after the 1st of April either need to have had a home reading, a 24-hour blood pressure reading, or to be added to the hypertension register and had the necessary change. The difficulty with CBD-01 is that if you do things that are just getting them over the line or doing things just to achieve that indicator, it may affect your achievement of CBD-02. So hopefully the aim is to get the people appropriately investigated and diagnosed. And there's a desktop exercise there to have a look at all of those patients who have high readings to see whether or not they already meet the criteria, or whether there's something very easy they can do, either through home blood pressure reading, referral for 24-hour blood pressure, referral through to the pharmacy for the hypertension case finding service, or other ways in which they can get onto the register as appropriate, but at least being investigated. Hopefully that makes sense. But one of the things that is always helpful to have is a machine that patients can access, whether that's a machine in reception or a machine they can be loaned or access out in the community as well. We've got just a minute left. Is there a list of templates? Natalie, I think it'd be good for you to maybe to link in with one of the support team from that diagram about what's available, and what you may need for your needs. Okay, I can't see any more questions on there. I can't see any more hands. Sorry, Susie, go ahead.
Yeah, I just wanted to ask, which is very good.
Sorry, your microphone's not by your mouth. Can you just bring that? I can't quite hear you.
Sorry. So I was just saying about the working together thing, that how we can work in which areas you can help, which is very good for the PCNs as well. If you want to involve us as PCN liaison managers, we would be we would be happy to come around and have these talks. Is there a steering group? How do you do them, and do we need to email someone for them?
So as far as I'm aware, currently there isn't a panel group that comes together. I know in some areas that there are groups based on the boroughs or their places. I think what may be helpful for it is for us to have a meeting with as many of the managers, development managers, the liaison managers together to understand your needs. And we could probably start off at a borough base, and then perhaps come back to now. So we'll ask to link in with yourselves and see how we can best coordinate that. But I think that spirit of collaboration is going to be really important in driving up the improvements across now.
Yeah, definitely. Thank you then.
Okay, and that's that positive note. I think we should end it there. Thank you all for your contributions and good questions. Hope that's helpful. We really appreciate some feedback on what is useful and what else we can do to support. Please get in touch, use those emails that's there, and we hope to see you either tomorrow on the cancer tool webinar, or also on the webinar on the 2nd of November, and any future ones that we may have. Thank you to the team, thank you to everyone else, and we'll see you soon. Bye for now.
Thank you.